Hello again. I decided to do a short chapter on bile duct disease. And the reason I did is because I came to understand that a lot of patients don't know what a bile duct is. They've heard about the gallbladder. None of this is really taught to them. And so I thought they should at least know about that. There's a lot of misunderstandings having to do with the bile duct and gallbladder disease, as you might expect. I think patients don't understand that once the gallbladder is removed, there can be problems later on having to do with the bile duct. So I wrote this chapter for patients to understand better what the situation was as far as that goes. So gallstones are fairly common, and certain populations have more than others. When you have gallstones in the gallbladder, about 10% of them can pass through the bile duct into the intestine and then be incorporated into stool and pass in the bowel movement. However, they can get stuck at the end of the bile duct. There's a muscle there, and there can be inflammation or narrowing or stricture formation or even tumor formation that can cause obstruction of the bile duct. So it was not uncommon for us in gastroenterology who could perform ERCP, which was endoscopic approach to stones in the bile duct. It was not uncommon for us to get called having to do with this. And I did also cover this in the chapter on complications, and I covered ERCP. So well, it's also important to realize you can have gallstone pancreatitis. So a gallstone can pass down into the bottom of the bile duct where it meets the intestine, and the pancreatic duct hooks into that bile duct area down at the bottom of the bile duct as it enters the intestine. So it can be obstructed with a stone, and you can get what's called gallstone pancreatitis, which can be alleviated by the removal of a stone down there. So this is a lot of the time our approach to the patient. So gallstone pancreatitis can be severe, and if there are guidelines having to do with when do you intervene, certainly infection also is a very important indication for intervention. If you have infection with obstruction of the bile duct, you want to alleviate that as soon as possible, get the patient on antibiotics. They may need to be stabilized first, and this sort of thing. These are important things to think about and contemplate and decide upon, and decisions are important having to do with this. So at any rate, the bile duct is left behind after the gallbladder is removed, and most of the time the bile duct is looked at the time of gallbladder surgery, is injected with dye and checked for stones in the bile duct, because if they're there, they should be removed really before the patient is released from the hospital, because otherwise there may be complications such as obstruction of the bile duct where the patient turns yellow, infection, and that can be deadly, and pancreatitis as well. So those are important considerations. Now, if the patient has symptomatic gallstones, they're a candidate for gallbladder surgery. And the longer you wait to have this done, the more likely there'll be complications like gallstone pancreatitis or infection. You can have perforation of the gallbladder where a hole develops there and there's an emergency situation. All those types of complications are what you're trying to avoid in such patients. There are patients that should have their gallbladder removed even without obvious stones. Some of them are symptomatic and have trouble with the motility of their gallbladder, and it gives them pain. So that's an important indication. There are patients that have a family history of gallbladder cancer, and those should be removed prophylactically to prevent gallbladder cancer. So you have to think about those types of things as well. There are patients that need to have the bottom of their bile duct opened up with an endoscope. with ERCP who have no obvious stones. They may have what looks like obstruction, may have inflammation at the bottom of the bile duct, or even cancer or tumors. They can have a motility problem where they just have pain, abnormal liver enzymes, and dilated bile duct. So those are also fall in the category of motility disorders. Used to be and still is called sphincter Bode dysfunction. Some people call it papillary stenosis. So there's various terms, but they can be indications for intervention. So I thought it would be important to bring up and discuss and look at the bile duct. I left, there are a couple of pictures in the textbook. In fact, I think they're the only pictures there that talk about the bile duct, so it makes patients understand a little bit better what the situation and anatomy is like there. I think it's important to realize, as I mentioned before, that ERCP can be accomplished successfully without complications most of the time and experienced in doctors who are experienced with this and have a good track record. So, and also it's thought to be less invasive, certainly, than common bile duct exploration done at surgery. So I think that's all I'm going to say on this chapter. And thank you for your attention.